Hello, everyone. Welcome to Facebook Live, our Let's Chat on intimacy after cancer. My name is Dr. Diana Bitner, and I'm the CMO, Chief Medical Officer, and co-founder and physician at True Women's Health here in West Michigan. We're so glad that you're here tonight to talk about this topic that can be a little difficult to get the conversation going. But what I've learned is that once we get this conversation going, the box opens and out comes all this very important information that's very near and dear to people's hearts. And once we just start the conversation. So tonight we're going to talk about intimacy and what happens after or during even the cancer journey. A little bookkeeping first. First of all, put your questions in the sidebar. I will see them and be able to respond. If it's a question that's a little sensitive and you might not want to put it in the chat with your name on it, feel free to personal message, and Missy, who handles our webpage and our communications, will see it and she will message me with that question. Or certainly feel free to personal message us after this talk and we will get to your answer. Also, we've kept this RSVP list private, so no one else will be able to see that you're on this talk if that feels a little private to you for this to be on a more public forum. So please know that we're very sensitive to this topic. I'm going to be very candid on this Let's Chat about intimacy. And so if there's little ears around, you might want to put in earbuds. Some of you have told me that you listen to this on your porch with your phone, off by yourself anyway, so that's great. But if you, again, are in a public space with little ears, you might want to put some earphones in. And so, again, I just want to be candid and give you a little bit of warning, or a heads up, rather. Another bit of bookkeeping is I want to call your attention to a blog created by a colleague and good friend of mine, Jim Simon, Dr. Jim Simon, who's been named the Menopause Whisperer by the Washingtonian magazine in DC. Jim was kind enough to share his valued opinions and experience with us in a blog about what men can expect about sex after menopause. And this is a blog that is very insightful. And, sex after menopause is something that partners, male or female, same sex or heterosexual partners, they're very concerned about how to bring this up. And I found that a lot of people are just afraid of getting in trouble, of bringing up a topic, and no one knows how to talk about it. And so this article can be really helpful to share with your partner and get the conversation going about what to expect and how to have a healthy sex life as our bodies change. Also, for some bookkeeping, our next Let's Chat will be on September 30th, and will be about getting back into your routines and taking care of your health again. I don't know about you, but even though my kids are older and only one in school anymore, it's just my time where I kind of get back in my routine and get out of that summer mode of I can stay up late and maybe have that extra cocktail. So it's a time to get back into our routine. We want to talk about what we can help, what we can do for you and support your health here at True Women's Health as you get back into those routines. But I really want to get into the meat of our conversation tonight. There's so much to talk about. I have notes in front of me because I'm just so afraid I might get excited and on one topic and forget to cover something. This is something that is near and dear to my heart, and I have just found so much. I'm so blessed to be able to take care of people with concerns about this topic. And so, to get started, just to give an overview of what we're going to talk about tonight, we'll try to keep it to around 40 minutes, but sometimes it just goes over. But we'll try to keep it to that. And basically, I want to talk about why I care about this as an OBGYN and some facts or information about the basics. And then we'll get a little bit into more of the details about what's involved in terms of thinking about intimacy or sex after cancer treatment, and what women can do about it. So I really want to offer the why these things happen, or why intimacy concerns or sexual dysfunction happens, and then what to do about it. Some very practical solutions. So again, as I think about why I care about this, for years, of course, I'm an OBGYN. I was very busy delivering babies and doing surgeries, and never crossed my mind about taking care of women who have gone through breast cancer or uterine cancer, ovarian cancer, anal cancer, leukemia, lymphoma. All these treatments involve, let's say, chemotherapy or surgery that can put women into premature menopause, or if they're already in menopause, make the issues of menopause a lot worse. And so, again, never crossed my mind, never got to see women with this condition. And as I learned more and more about what happens, I was just mortified. And then to see women talk about sexual health. And for years, I didn't know how to talk about it. I didn't know why women would have sexual health concerns. I didn't know what a big deal it was. And I didn't know any solutions. So us doctors like to fix stuff. And so if I can't offer you a solution, then it's really hard for me to talk about it. So again, I want to talk about sexual health after, cancer, because it is such a big deal. Sexual health is about so much more than preventing a sexually transmitted infection. It's about so much more than, sexual health in terms of not having sexual violence or not having to have sex when you don't want to, but it's about sexual health. It's about how it is part of your overall health. And I care about this because I've seen women break down and cry because they feel broken after cancer or with menopause. They feel damaged. They feel so isolated and alone. They feel guilty that they're not being a real, part of their partnership. They're not being an active member in their sexual relationship like they were, with their partner in the past. And so it's just heartbreaking to see how people say, cancer has taken so much from me. I've gone through so much to survive the treatment. I feel guilty almost that I am grateful for the treatment that saved my life, that treated my cancer, but it has taken so much from me. I don't know what to do. I feel like I've been harmed even more than good. The other reason I care about this so much is the other side, is the flip side. It's the side where women walk into the office, with their head down and feeling so sad and upset, like, how do I talk about this? And they leave with hope. They leave with, oh my gosh, I don't have to live like that. There are solutions. I'm not alone. I'm not the only one with this issue. They leave my office with language of how to talk to their partner about sex. What is sex? They're able to have that conversation, to start to feel, like, okay, I can do this. It is possible. And to see women light up with, oh my gosh, I have a partner in my health. I have someone who understands. All women deserve this information, and all women deserve to know this. And by the way, hello, Nicole. Hello, Michelle. I'm so glad you've joined. So, again, this is something that it's just really, I can't believe that I get to do this work and I get to be involved in patients' lives with this. One thing that also, makes me sad about, but then also makes me happy when we can resolve it, is so many women will be really afraid to have the conversation. They say that they feel like their other healthcare providers, the cancer specialists, it's more like, okay, you had cancer, you should just be happy to be alive. We're not going to talk about sex, or sex is probably not even on her mind. It's, the numbness from the chemotherapy in her toes. She's probably not even thinking about sex. Oh, everyone, she's thinking about sex. Her partner's thinking about sex, because that's what helps them feel normal and connected and close. It's part of, again, feeling normal. And as I thought about this, a little earlier, I remembered a patient of mine who said, after she had radiation therapy, she had anal cancer, and she had radiation therapy down there on her bottom and the area where the cancer is. And a couple days after treatment, she was really suffering. The radiation, which is life-saving, it prevents big surgeries. Most people recover really well. But the couple days after surgery, after radiation, she had pretty significant burns on her skin and a lot of pain, a lot of diarrhea, a lot of discomfort. And she just wanted to be hugged. She just wanted to be held by her partner, by her husband. And she felt so guilty that being sexual wouldn't even be part of the equation because of all that was going on down there with pain, with discomfort. And she just wanted to heal, but she wanted to be held. And she didn't know how to ask her husband, will you just hold me? She was so afraid that if there was any intimacy, it would lead to feelings of guilt about not wanting to be sexual. She was so afraid that it would make her husband think about being intimate. He would feel sad or mad that they couldn't be intimate, and it would make him feel rejected or, whatever. And so she remembers falling asleep, both of them in the same bed, back to back, and she fell asleep with tears in her eyes. I get shivers thinking about it. She had tears in her eyes because she felt so alone and so isolated, and they were back to back and just felt like, I feel really distant. If she had had the language to say, honey, I just want to be held. Will you help me through this? We'll stay close. It's going to be okay. And I know that we'll be able to get back to intimacy in the future. And that would have created such an opening for a conversation. She just didn't have the language. And so I talked to all my patients about a phrase, a word, just to get them started. And in a little bit, we're going to talk about one of the tools that I now use with all my patients, and that it's available on our website if it's something that would be helpful to you. Again, we think about how daily life is difficult to navigate after a cancer diagnosis, but 85 to 90% of women have issues with intimacy or sexual health after cancer treatment. So again, that can be any cancer treatment, not just cancer of the vulva, the ovary, the uterus, the cervix. It can be cancer, leukemia, lymphoma, lung cancer treatment. And again, a lot of these really strong chemotherapies will put women into menopause. So I take care of women who are in menopause at 22. The youngest patient I've taken care of with menopause is 15. So 15 meaning her ovaries are done. Premature menopause from chemotherapy. And again, I so want to see these people so I can help them know that they are okay and there are options. So again, tonight we're going to talk about what to do about sexual health after cancer. And again, how women can still continue to feel young and healthy and sexy and vibrant and young and not broken. Now, sometimes people will say to me, of course, I'll ask everyone about sexual health, and they'll say, I'm good. They'll say, hey, I've never really been that sexual. We got married knowing that I wasn't really that sexual. We figured out how to navigate that. So yes, I have low sex drive, and I'm really okay with that. And it's okay in my relationship, and we're okay with this. Then you know what, guys? It's not a problem. It's only a problem if it's a problem. And so again, also for people to accept the fact that just because we're talking about this now and there might be more conversation going on out there, it doesn't mean that we all have to have this same identity of being sexual or what that means. So, one thing we talk about is hypoactive sexual desire disorder. It's a medical condition where the switch just gets turned off. There's no other reason other than that switch gets turned off in the brain. There's no relationship issues. There's no hormone issues. There's no history of cancer. We know that for some people, again, that switch just gets turned off. And so if it's a problem, then it's a problem. But it's defined by the fact that it is persistent and it causes distress to the couple or to the patient. And then we now have at least 2 medical options that are FDA approved for treatment of HSDD. So again, please don't be shy about talking about this with your provider. So low sexual desire. We're going to talk about this tonight in the context of cancer treatment or the cancer journey. I remember going to so many medical meetings about this. ISSWSH, the International Society for the Study of Women's Sexual Health. ISSWSH is such a powerful organization, and it is possible that you go to the ISSWSH website and actually find a provider who is on the ISSWSH website. They're members of ISSWSH. They've been trained in sexual health. And the other, of course, is NAMS, or the North American Menopause Society. These organizations are so about evidence-based treatment and teaching us providers how to talk about sexual health with our patients. The problem is that I used to sit in the back of these meetings and hear incredible lectures by my colleagues. Cheryl Kingsburg, she's been on with me before. By Dr. Jim Simon, he's been on Let's Chat with me before. And again, I referenced his article. So I hear these amazing lectures and I think, how am I going to remember all this when I go back to talk to my patients? So I invented the sex deck. The sex deck is available on our website. And it's just been a wonderful tool to help me talk to my patients about this, and also for them to then take the sex deck home and talk to their partners about sexual health, or even just to take it home and reflect, on themselves on the conversation. And so I'm going to show you the sex deck, and then we're going to go through a couple cards separately. So the sex deck is the 27 reasons for low sex drive or low desire. And there are 27 reasons, and I group them by physical, psychological, and interpersonal reasons. And again, we're going to go through a couple of these cards together tonight. So again, it talks about how, again, low desire can be a medical condition or a real condition. Some women will say, I feel like I've lost it. I don't have it anymore. If I don't ever have sex again, I don't care, but don't tell my partner. But I don't care. I've just lost it. And as we start to go through all these different reasons for low desire, they're like, oh, maybe I haven't lost it. Maybe just there's other stuff going on. And so again, these are the 3 categories of reasons for low sexual desire. If you choose to get the sex deck, what happens is that you'll look on the front of the card and there's the reason. So this card is incontinence. So, it's not very sexy to leak urine or BM during sex, right? So if you're concerned about incontinence, it's probably going to keep you from wanting to get naked and to have sex. So on the back of the card is the causes of incontinence and what we can do about it. So this is something we talk about all the time, and it's very common, and there are solutions. So again, but it's a reason to say, I'm not interested in sex, and just to put it out of the mind to the point where you don't even want to go there. And so when I think about cancer, the cancer journey, the cancer diagnosis, the cancer treatment, there are a couple cards I think about more specifically. And of course, a main thing that we talk about a lot, and that is very common, is, I'm looking at the cards here, painful sex and vaginal dryness. So when I think about painful sex, when I talk about or think about painful sex, it's basically one of 3 reasons, or for some women, it's all 3 together. And so before I even ask women details about their situation, their own experience, I first just sort of give a framework. So pain with sex is generally caused by these 3 things. Number 1, by the skin on the outside. So the skin on the outside of the vagina is called the vulva. There's the labia minora, the labia majora. And if there's skin conditions on the outside, if there's dryness from low estrogen, if there is a skin condition that's very common called lichen sclerosis, think of it like eczema. So I'm very happy calling the parts down there, the vagina, the vulva, the urethra, but sometimes we just have a little bit fun with it. We call it lady town. So, if you have, eczema of the lady town, we call it, I'm being silly, sorry, lichen sclerosis. So lichen sclerosis is a medical condition that we can treat with a steroid ointment. We can treat it with a Monalisa. And so it's something that's very treatable. But if the skin on the outside is really dry, really tight, and doesn't stretch, of course, it's going to cause a lot of pain with just even general touch. It's going to make it very difficult to have an orgasm because there's not room in the brain for orgasm and pain at the same time. So if there's pain or discomfort, or if you've been scratching because of the skin condition and you're like, I just don't want anything going on down there, then it's going to be really difficult to want to have sex, and it can lead to low desire. When we talk about treatment options for skin on the outside, number 1 is being diagnosed properly. So it's seeing a gynecologist or a primary care or a nurse midwife or a nurse practitioner or a PA like Suzanne, who works with me at True. It's having that diagnosis. And when we think about the skin on the outside, what are the treatment options? So number 1, it's being treated for lichen sclerosis with what you see listed under the screen with clobetasol. It's a class 3. It's a very strong steroid, but we recommend it in very tiny amounts on the areas of the skin that are affected by lichen. If you have lichen and it goes untreated for years and years, it can lead to cancer of the vulva. So we want to make sure that if you have this, you're diagnosed correctly. We follow it closely. If there are areas that we're concerned about on the skin, then we would recommend a biopsy of the skin, of the vulva, and we can do that at True, or again, any gynecologist or primary care doc who is seeing you for this condition could also do that biopsy and make sure you're okay. And then again, be real intent have great intent about treating it and seeing you back to make sure the treatment's working and that you're putting the ointment in the right place. Excuse me. So another treatment for lichen, we don't have level 1 evidence yet on the treatment of the Monalisa Laser for lichen, but anecdotally, a lot of my colleagues who have done Monalisa many more times than I have on patients, talk about the fact that the Monalisa Laser is likely very effective. It's certainly not unsafe, but very likely effective for treating lichen sclerosis because of how the laser works. And we'll talk about the laser a little bit more in a second when we talk about vaginal dryness and painful sex from that. But these are treatments for the skin on the outside. Also, a dilator can be very important. So when the skin of the vulva gets really tight because of skin conditions on the top, the lichen, or down in the bottom, or dryness around the opening, again, the opening can get very tight. And even though we might treat it, let's say with vaginal estrogen, with testosterone right at the 6 o'clock place for vestibulitis, if we treat with estrogen on the inside, if we treat with clobetasol and we treat the lichen, if we treat with DHEA or Interosa is the brand name, if we treat the skin with these conditions, but still we're not getting the skin to stretch out, it can have a lot of memory of, you're not going there because that hurt last time. So that's where a dilator can be very important. And so again, I brought home from the office the dilator that we recommend. The other dilators that we use, I didn't have one right handy. It's called Soul Source. Soul Source is a dilator that comes in all different sizes. But another option is Millie. So Millie is a dilator that we show women at the office, and it's a dilator that once it's inserted, it can be increased or decreased in size. So what happens is, again, this is not a sex toy. It does vibrate, but it vibrates to treat the muscle spasms that we'll talk about in a minute. But it's a dilator that helps women slowly stretch out that skin again. And so once the dilator is in the vagina, it just increases in size slowly. And what we recommend is women use this 10 minutes every day in a non-sexual sense. So why do I say that? If this is used in a sexual sense, then your brain is going to remember that it causes pain and associate pain with sex. So again, it's not going to cause, I guess, shouldn't say pain, discomfort, right? But we want sex to be separate from treatment of that skin having been tight. So again, as women use the dilator, put it inside, take it up to that size that's just like a little bit uncomfortable, cover up and watch TV for 10 minutes. And it's okay to put a lube. We're going to talk about lube. Good Clean Love is my favorite lube to recommend. I don't get any kickbacks from this. We're not looking to make money. We sell it at the office at list price because I really believe in it as a very safe, it's all natural, free of parabens, free of all those things that you can't understand on the back. Everything here is natural. It's osmolar balance, like all those electrolytes like are in Gatorade. All that's balanced and the pH is balanced. And what it does is it's a safe lubricant that you can use with Millie or the Soul Source silicone dilators. And so it's really helpful to have a safe lube. Again, put Millie in, turn it up to the size that is just uncomfortable, cover up and watch TV or read a book, and really let that skin stretch slowly. When we talk, so that's sort of a brief about skin on the outside. Now let's talk about skin on the inside. So skin on the inside, we generally think about the biggest issue is vaginal dryness. So that's another card in the sex deck. Vaginal dryness, if you look on the back, causes our menopause or low estrogen, low vaginal estrogen. Women who have had pelvic radiation treatment can cause a lot of dryness and stiffness in that skin. For women who have had breast cancer, use of tamoxifen or aromatase inhibitors, those are medicines that lower or block estrogen to help reduce the risk of the breast cancer returning. So those medications, and also being postpartum and just having had a baby and breastfeeding, can also cause vaginal dryness. So what are the options for treatment? Again, it's right on the back of the card. An option for treatment is use of hormone medications is one option. Now, for women who have a history of breast cancer, they might be real concerned about using anything vaginal estrogen. For many women with breast cancer, it's actually safe to use vaginal estrogen, especially a brand called Imvexxy, because they've done really good studies to show that it does not go in your blood. But again, some women just choose not to go that direction. They might use vaginal DHEA. The brand name is Interosa. But they also will know that the Monalisa Laser is treatment for this condition. Now, this might be perfect for a woman who has a history of breast cancer. Either her oncologist said, I'm really not comfortable with you using estrogen, or she herself is not comfortable using any vaginal estrogen. The Monalisa Laser has been shown to be as effective as estrogen. Now, I chose to make a financial investment in this laser because the data is good. It's level 1 evidence published in medical journals that it's as good as estrogen. It's not better. So if you come in with estrogen, I'm going to say, I don't think this is going to make any better. I don't want to take your money. But I know that if you're not using vaginal estrogen, it's as good as vaginal estrogen. So what the Monalisa laser does is it actually causes little damaging, very superficial holes into the collagen, into the skin of the vagina and the vulva. And what it does is it creates that tissue injury that's short term and allows the skin to heal, and it regenerates the collagen and the skin and the mucus glands. What I want you to think about is that skin has collagen. Collagen is like the structure or the boards of the skin. And I don't know if any of those of you who have sewn out there, but when you sew elastic into pants, for example, you sew it way stretched out. So when the pants are the right size, it comes back in, and the elastic will look kind of squishy when it's all together and not stretched out. We want that elastic, that collagen of the skin to stretch, to be able to shrink and to stretch. Low estrogen and damage from radiation after radiation therapy for cancer damages that collagen. It breaks it. It becomes brittle and thin, and there's no more undulations, or we call them ready pegs. Or even on biopsy, the collagen looks super flat and it can't stretch. Also, in skin that has had a radiation or has had low estrogen, the mucus glands are dried up. The skin gets really thin. The blood vessels are very really not there. Now, in women who have had significant pelvic radiation, I wouldn't necessarily recommend the Monalisa laser unless there's already some healthy tissue. I'm just not going to tell you that it's going to be maybe that effective. But certainly for women who have had just maybe 3 doses of radiation for uterine cancer, or again, women who have had menopause, the Monalisa laser is very effective to help open the vagina back up, make that skin stretchy, make it lubricate. So if you're thinking about sex, you're able to have arousal and really able to have sex without pain. So I feel very good about that. Of course, also for very mild symptoms, a lubricant is important. Again, the good, clean love is something that is effective and very safe and without additives, but also a moisturizer. So again, a lube is to be used at the time of a vaginal dilator or at the time of intercourse. A moisturizer is something that one uses on a regular basis. So there's different brands out there. I'm really proud to talk about this. Again, no kickbacks. I'm not taking advertising money from them. I just think this is a really good product because there's not a bunch of junk in it. It's all natural. There's no parabens, and it is effective. The happy vagina has an acid level or a pH of 4. So some women say at first this feels maybe a little stingy because, again, it's a little bit acidic because that's a happy vagina. A happy vagina has that pH of 4, which supports the really healthy bacteria. It doesn't support the unhealthy or the stinky bacteria. So if you've got a vaginal discharge, a little bit of extra odor, then that is bugging you, then this moisturizer can be really helpful to support the healthy bacteria and get rid of those symptoms, maybe even without antibiotics. So again, that's a discussion to have with your provider, but it's certainly an option. The other thing that I want to talk about, the skin on the inside, is that a lot of women will develop painful sex and their body remembers the painful sex. So this also applies to the next category, which is the pelvic muscles. So I want to talk about the pelvic muscles as we think about the next treatment. So the pelvic floor are the muscles inside the bowl of the pelvis. I want you to think about the pelvis as like a bowl. The bones of the pelvis are like a bowl, and our femurs attach up into our hips, and we have our sacrum in the back and our pubic bone in the front. And so it's a bowl that supports all our parts. So the bowels are held up, the uterus, if you still have one, it's being held up, your bladder, of course, and your rectum and your bowels. And so it's all held up in place. The pelvis has lots of muscles, and the muscles are all this way, and they're back and forth, and they're around each opening to help keep the stuff up inside when we want it inside and to let it come out when we want to urinate or or have a BM, or of course have a baby. So these muscles are very complicated. These muscles are very protective. So if you had pain with sex even a couple times, so where's the card on painful sex? It's in here somewhere. But in painful sex, what happens is, again, the body develops memory. And so when you try to have sex again, even though you're like, okay, I got this, I'm going to relax, we treated it, it's all good. But if your body remembers that you had pain and you try to have intercourse or penetration, your muscles say, you're not coming in here. Are you kidding me? What are you thinking up there? So the muscles will close down and spasm. So we used to call it vaginismus. Basically, it's spasm of the pelvic muscles that are there to protect you. Women who have this will say it feels like he's hitting a wall, or it feels like that dilator or that vibrator is hitting a wall and it can't go in any further. Like, what's in there? I'll say, well, nothing's in there. It looks normal. But in a sexual context, those muscles will just shut down. So we have to teach those muscles to open back up again. And to do that, we have to practice, again, in a non-sexual sense. So I want you to think about, if you're going to stretch your legs out before you go for a run, it's the same kind of thing. But how do you stretch out those muscles up inside there? So, of course, we have wonderful pelvic floor physical therapists that can help teach us how to relax on the outside in terms of hips and legs and core, but also to relax on the inside in terms of how to relax those pelvic muscles. So it's not just Kegels to tighten them up and pull them up, but also to learn how to relax those muscles and let them go. And again, what can be really important is, for example, having Millie. So, Millie is something, again, that some women start, they can barely get Millie in. And this is, I think, this is the smallest she goes. But once Millie gets in there, she opens up to how large you might want your vagina to be able to stretch to. And so it's to allow those muscles to realize, oh, okay, we treated the cause of pain. There's no more pain. I'm good. But it takes time. So when women come in and they say, I have itching on the outside, I have pain on the inside, and I try to have sex and there's just no way. And I do an exam, and again, we go through everything that's involved, and they say, there's no way. I'm just so worried that there's nothing that we can do. And I always say, maybe I shouldn't be so glib, but there's never been a bottom I can't fix. There's never been a bottom. But I will say to women, it's going to take some work. This isn't just a magic wand. This isn't a magic pill. This is going to take work on your part. And part of that work, it might take 4 weeks of every day using Millie to get your muscles to chill out. One tool that we use as well is vaginal Valium. So Valium is a medicine that you might know of as an anti-anxiety medicine. It helps relax the brain, chill out, not react to stress. Very addictive. We have to be careful. But Valium is also a really wonderful muscle relaxant. So I tell people it's what we use for hiccups, for example. So if someone has hiccups that don't go away, 1 dose of Valium relaxes the diaphragm, hiccups go away. We use the Valium if someone has an IUD placed and they've never had a baby, the muscle, contracts, the Valium helps that relax. But also we use it in the vagina to treat pelvic floor spasm. And we use it by just using the regular prescription Valium. You take the little pill, put it under a faucet, get it wet, put it up in the vagina. So it can have some systemic absorption. It's important not to drink alcohol with it or drive a car or operate heavy machinery after using vaginal Valium, but it can be a real tool to use before a dilator the first couple times, before that first couple session of pelvic floor physical therapy, and even to use that before intercourse to make the body not worry about it so much. And then again, it's all about desensitization, and that's where we're going to talk about the OhNut. So desensitization, what does that mean? That means slow progression, slow return to intercourse. So I'll have patients that will say after a couple sessions with their pelvic floor physical therapist, once they've started using, let's say, vaginal estrogen or DHEA, or they've had the laser, like, woohoo, I want to go return right back to intercourse. I'll say, slow it down. If you right away try to go back to full, intercourse or penetration, it might hurt again because your body freaks out, and then you're going to set yourself back a whole nother month, and all that good work, will be set back. So it's really important to start slow. So start with a small dilator, a small vibrator, just to gradually increase. But for some women, they say that's so hard, we want to resume activity as soon as possible. So to the people who developed the OhNut, kudos to them. So I explain this to women. Remember the teething rings? For those of you who have kids, remember those teething rings that with multicolors that we would stack on the little block, you know, the different colors. So the OhNut looks like that. So the OhNut is made of these different stacking, I don't know what you call them, but the different pieces of the OhNut. And basically on the dilator or on an erect penis, these are stacked up one by one. Well, in one pack, there's 4. So we sell these at the office, or you can get them online. And basically they're stacked up, and then there's only as much as can go in. And if you need 2 stacks, okay, good for you. But it's having as many stacks, and then as sex becomes more comfortable, as intercourse or penetration becomes more comfortable, then time by time you remove the rings. Now, if your partner is a male and this is on an erect penis, this still feels good to them. They don't know the difference, maybe, that they're not going all the way inside. But for you, there's not that fear of, you know, not being able to control the depth. And so it can be a really nice gradual way to return to intercourse and penetration without fear. And it can be very satisfying, and again, really allow people to get back to, you know, that intimacy. And again, that just makes me think again, you know, it's so important to think about intimacy. Again, it helps people feel like, okay, I've been through breast cancer, uterine cancer, cervical cancer. How can I get back to normal? And, you know, we talk about what is sex. Sex doesn't just have to mean penetration and mutual orgasm, right? It means pleasure, and it means intimacy. And what sex looks like at 60 or at 70 or at 90 might look a lot different than what it looked like at 20, at 25. It looks a lot different, but it's still sex. And so when we talk about penetration, for some people, that's a really part of feeling really close to their partner, to have that penetration. And again, there are ways to help women, help partners get back to that. So that might be a lot of information, but this is stuff, again, at True, we're very comfortable talking about. We have all these that you can see, you know, in the office, and that you can hold them and touch them, and they really make a difference. So another thing that I want to talk about is self-image. So, you know, one of the cards of the sex deck is self-image. And so when we think about what are the causes of poor self-image, so for example, I had a patient who had breast cancer. She had a bilateral mastectomy. She went through therapy. She was feeling pretty good. And she chose to have reconstruction. And with reconstruction, she had a mastectomy that removed all the skin, or a majority of the skin. And she had to have it stretched back with expanders. She had the nipple in that area removed as well. And so she really had decreased sensation. And she said, you know, to anybody, that these breasts might look okay, but they don't feel like me. I don't have sensation. My breasts used to be a really big part of my sexuality, and I don't have that anymore. And so I don't feel as sexy. I don't feel as much like a woman. Now, her partner was a man, and her husband, and he was like, they look pretty good to me. I'm okay. So she really had a hard time communicating. They might look okay, but I don't feel as much like myself. I don't feel sexy. And so we had to talk about that, but she really did want to be intimate with her husband again. She wanted to have sex again and not let that bother her. And she really talked about wanting to get past that. So we even talked about, you know, just that language to her husband. Is it okay if I don't have them exposed? Is it okay with you if I just, let's say I wear a t-shirt, and we'll really focus on other areas that worked for us in the past. So in terms of getting back to intercourse and having outer course and having orgasm together, to really get past that. But when we think about self-image, we think about, you know, women feeling unattractive. It's about an unwanted weight gain. You know, a lot of women after cancer think they're going to have weight loss, if maybe they always wanted to lose that extra 10 pounds, but they thought, oh, I'll have weight loss. And actually, unfortunately, after chemotherapy is done and healing, a lot of women in menopause will gain weight, especially in the midsection. So if it's a woman who's 35 and she always was proud and she felt really good about her flat belly, and now after breast cancer, she's in premature menopause, and now she has belly fat. Now she has bra fat. Now she has that fat that makes her feel like, whose body is this? It really can affect her self-image. And again, one action, of course, is to talk about what are the tricks of losing weight after menopause. There are definitely tricks, it's definitely possible. But in the meantime, how can we take that out of the equation? And I had a patient who said, well, it just so reminds me of that when he touches my belly, it reminds me I feel fat. It makes me feel old. It makes me feel unattractive. It makes me feel like I'm not me anymore. And so I said, well, maybe could you say to him, could you just not touch my belly? She's like, well, that's it. And so she went home and she said to her husband, could you just not touch my belly? I'll have sex if you don't touch my belly. And he's like, that's all I have to do to have more sex is not touch your belly? I can do that. And so she just laughed that that was a great solution, that they just had that as a safe word, that don't touch my belly. And they were able to slowly resume. And as she felt better and we got her more active again, then she was able to lose that weight and it wasn't an issue. Again, scars can be a big deal. My patients who have suffered ovarian cancer or uterine cancer, they have potentially scarring, especially women who have had repeat surgeries for recurrence. Their scars are really difficult. And you and I might look at their scars, or their partner might look at their scar and say, oh, honey, that's a battle wound. You should be proud of that. You should feel good about the fact that you had a treatment and now you're okay. But she'll say, no, it bothers me. I want it gone. Can I have more plastic surgery and have that scar taken off? And the answer might be no, it's not going to look any better. The scar is there, but it's then how do we deal with that? Is it wearing a t-shirt? Is it practicing gratitude around that scar? What is it? But, cognitive behavioral therapy is therapy that's really effective, especially with someone well trained in cognitive behavioral therapy, to really help us adjust to that change that we can't do anything about. The scar, the new breasts, the history of radiation therapy that sex will always be different. So it's really then seeing a therapist who's very comfortable and skilled in talking about the trauma, the grief, being able to get that in the open, having some acceptance, and then being able to move on. And so, that's a big deal. Distraction is another card. I don't see it right in front of me, but distraction is another card. So women will say, I'm distracted by worrying about it might hurt. I'm worried about the kids coming in the room. I'm worried about, so distraction about self-image or even things going around us can really affect our desire to want to have sex. So super, super important. Another thing I want to talk about is lack of intimacy. So lack of intimacy can really cut down that sex drive. Again, it's an interpersonal reason. But, one thing is, for example, fear of recurrence. So how does that affect intimacy? I've had patients who tell me, my husband is so afraid that my cancer is going to come back that he doesn't want to go there in terms of even talk about the pelvis, talk about sex. He's so afraid that the cancer is going to come back. We don't want to change anything because he's worried that maybe it will increase the risk of it coming back. Or just that fear of breaking the scar, that fear of causing pain, and wondering how to talk about it. Again, it makes me so sad that when people don't have that intimacy about fear, fear is such a powerful motivator to keep people apart. And if we can just talk about our fears. So, for example, it's having that, lack of ability to talk about it. And so, I see women who say, again, I don't even want to hug him. I don't want to hold his hand. I don't want to do any of that because then he'll feel like, okay, great, now we get to have sex. And I don't want to turn him down. So if I don't hold his hand, if I don't sit close to him, if I don't hug him, then he won't want sex. Then I won't have to disappoint him. And poor Bobby, her husband is sitting there thinking, she doesn't want me. She doesn't love me. She doesn't want to even touch me. Like, what's wrong? Like, where did she go? Where did our relationship go? So it's all this unnecessary stuff that happens just because of the fear of having the conversation. And as people talk about things and say, I really want to talk about, I want to hold your hand. I want to hug you, but I'm not quite ready yet to be intimate. I'm not ready to have even outer course. I'm not ready to have intercourse. Can we just hold hands? Can we just snuggle? And as we're able to talk about this, I really look forward to wanting to have sex again. And again, I've had patients go home and have that conversation, sometimes really using the card, to say, look, this is real. This isn't just me. The doctor said, use my name. Let me be the heavy. Like, the doctor said this really is an issue and causes low sex drive, people just cry with relief to know that they can have this conversation and people don't have to be scared to talk about it. So lack of communication, all of that interpersonal stuff can really lead to poor sex drive. And again, I just pray that if anything that happens from tonight, that you have a little bit more language, you're able to talk about this in a different way, and it doesn't have to have the stigma of, cancer means no more intimacy, no more sex. I want to make sure I'm not forgetting to talk about anything here. Any questions at all? I see lots of you commenting. I'm looking on the sides, lots of good information. So not seeing any questions, so I'll keep talking. So one thing that also a lot of women deal with after cancer is fatigue. They call it chemo brain. They call it just fatigue. And we wonder, okay, why people say to me, why am I so tired? One thing, I'll take you back to the seeds. The seeds are the 7 essential elements of daily success. And the number 1 seed is water. So if you're not drinking enough water, you might be drinking enough water to urinate. You're not passing out. You're not going to the ER. You're hydrated enough, but you're not hydrated enough to feel that good energy. Your muscles are dry. They don't feel real strong. They fatigue really easy. It's amazing how women say, all I did different was drink my 80 ounces of water. Oh my God, I feel like a different person. So that first couple of days you drink all that water, you might go to the bathroom more. But over time, especially if you choose to use vaginal estrogen or the Monalisa Laser, then that skin stretches back out and your bladder will hold more water. So you don't have to go to the bathroom every 30 minutes. So drinking that water can really help with fatigue. Again, we're talking about fatigue because fatigue can cause lack of desire to have sex. Who wants to do something that takes some energy if you don't feel like doing anything, let alone have sex? Especially if your partner wants to initiate sex at night when the house is quiet, the kids are all asleep, like, hey, and you're like, are you kidding me? I can't even keep my eyes open, let alone want to have sex. And so fatigue is a really important thing. Poor sleep, of course, is a cause of fatigue. And let's say someone is in premature menopause or they've been in menopause and now it's even worse because of treatment. That menopause can cause poor sleep. It can cause hot flashes and night sweats and poor sleep that's disturbed. And so it's really getting at what are the solutions that fit for you? What are safe for you in terms of your cancer, your personal health, your personal situation? How can we help with sleep? Including a gratitude journal before bed, including meditation. For women who it's safe to take systemic estrogen. So I have patients who have had anal cancer at age 32. We start them back on estrogen and they can start to feel good again. And so for some women, that's a real option. Even taking a medication like the brand name Lexapro can help with night sweats. So women who have had breast cancer, Lexapro is a very safe medication to take that can help reduce night sweats, help women get a good night's sleep. Now they have more energy. Now they're able to be active, including wanting to have sex. Now, poor nutrition can also be a cause of fatigue. So let's say that you're recovering from chemotherapy and all you want is mashed potatoes. So it's a bland food, it's a comfort food for you, or people keep bringing you casseroles with white noodles. So if you eat a lot of sugar, including white flour, white rice, white tortillas, whatever it is in terms of a simple carb, that poor nutrition can cause fatigue by blood sugars fluctuating all over the place. So back to the seeds, we want you to have 5 complex carbs every day, like brown rice, like oatmeal, like Ezekiel bread, like whole wheat naan, like whole wheat tortillas, like farro and spelt, all these lovely ancient grains. So complex carbs help give us good nutrition and therefore good energy. Another cause of fatigue is lack of activity. So of course, if you've gone through chemotherapy, you've gone through radiation therapy, you probably haven't been real active for a bit. Or maybe that treatment's in the past, but you haven't resumed your normal activity. As you lose your muscle mass, you get tired. And so it's getting on a regimen that allows you to slowly return to activity, slowly build that muscle back up. So then you have activity to do those activities that you love, including have sex. Also, because of cancer treatment, because of what you've gone through, many women suffer periods of anxious mood, depressed mood, or truly clinical depression, clinical anxiety. And there's a very strong connection between estrogen and neurotransmitters or brain chemicals that mimic, let's say, PMDD, that mimic postpartum depression. So menopause-related depression or anxiety, again, it's a chemical disorder. It's not something people choose. So when people have anxiety and depression, the last thing they want to do is reach out and have sex. Or, for some that might be a real comfort if it's just mild. But if they have significant anxiety and depression, the last thing they do is choose for good nutrition or activity or exercise or sex. And so depression, anxiety can be a cause of poor sex drive. And again, by looking at the card, going through the list, you can use that as a checklist with your partner, with yourself, with your provider. If you're not in our area, not able to see us at True, it's to go on the website at themenopause.org and find a provider who's a menopause certified provider. It's to go to ISHWISH website, which we've listed on the side, that will show you where is a provider that's trained in sexual health. And also ASECT. ASECT is an organization that certifies, that shows who is certified in sexual health in terms of sexual health counseling. It's training that I've chosen not to pursue. It's quite an undertaking, but there are really good ASECT certified sexual health counselors or sex therapists in your area. And I have contacts with nationally acclaimed sexual health therapists that can do telehealth visits, and I can connect you. So we have really good resources if you need more therapy past what we can do for you at True or past someone who is not a licensed sex therapist. So again, we're really excited to offer, even we have a psychologist joining our office. And so she is someone who can talk to you about these basic issues of anxiety and depression right in the safety of True. And we can refer to others in town. And so we're very excited again to support the whole woman at True as related to anxiety and depression, but also then as that reaches out into how do we find our journey again after a cancer diagnosis and after cancer treatment and after premature menopause. So again, we have covered some of the causes of intimacy issues after cancer. These apply also, of course, to just plain old menopause. But again, it's talking about what is sex. It doesn't have to be, again, intercourse. It doesn't have to involve mutual orgasm, but it's pleasure, it's intimacy. And even as we talk about this as it applies to men's health, what I found is that, of course, many women, as they get older, their partners might also suffer from sexual dysfunction. So, for example, erectile dysfunction, so ED. So women will say, well, you can help me be able to have intercourse again, but that's not happening for us as a couple. So I still want to talk about treatment to feel more comfortable down there in terms of my skin be healthy. Maybe I can have an orgasm again because now I've got blood flow again down there, but I don't worry so much about intercourse. So then, of course, I say, if your husband has ED, are you even comfortable talking about sex with him? And she says, are you kidding? He doesn't want to talk about it at all because it reminds him that he can't have an erection anymore and it makes him feel like less than a man. So I'll say, well, did you know that he could have an orgasm even without an erection? That usually stops at the moment of silence. She's like, no, I don't think he knows that. So the nerves for an erection and an orgasm are different. I learned that from Dr. Humphreys, the urologist. We gave a talk at Gilda's Club one year on sex after cancer. And he taught me about how men can still have an orgasm without an erection. And so if the couple can get past the fact that it doesn't get hard anymore, so what? Let's still be intimate. So the same happens for men as can happen for women. And again, what is sex? It's pleasure and it's intimacy. It's something you do with someone that you don't do with anyone else. It creates that personal part of the relationship. And again, for people who have gone through, let's say, even a heart attack or a stroke or a cancer diagnosis or whatever it is, sometimes just being intimate and close and private in a sexual sense is a very healing time. So we want women to know, men to know that good sexual health, good intimacy is very possible. That's what we love to do at True, is show you that it is possible. Your goals are very real, they're very important, and we want to support you in reaching that goals. And so on that note, I want to again remind you, I can't wait till you meet Suzanne Pettigrew. She is a PA who is very experienced in primary care, but has specialized training in cancer as it relates to risk assessment, as it relates to cancer survivorship, and as it relates to menopause. She is trained in sexual health as well as all the effects of cancer treatment and has started several programs about cancer survivorship. And we're so fortunate to have her at True. And so as a teaser, we can't wait to tell you more about the cancer survivorship program. We'll be rolling out at True very soon and look forward to telling you more. And also part of our wellness program is to talk about what is your risk for cancer. So the other aspect of the conversation about tonight is, I hope if you're listening that you haven't had cancer, you might be concerned about your risk for cancer. You might have been told you have very high risk for breast cancer because of Lynch syndrome or a genetic mutation called BRCA1 or BRCA2 or PLA or any of these other genetic mutations. And so you're very concerned about what is that going to mean? And so at True, we're able to do an assessment of your risk of cancer. And then we can make recommendations regarding high-risk screening. We can connect you with specialists in the area of cancer in our community and even nationwide. We have colleagues all over the country. And so we're very able to talk about those risks you might have for cancer, how to help you reduce those risks. I'll ask many a woman, do you want to have cancer? And of course, the first response is almost anger. Like, what do you think? You think I want cancer? But most women don't know that there's choice. So for example, women say, I really don't want breast cancer. And I'll say, it's kind of like what my mom used to say. Your actions speak so loud, I can hardly hear your words. Those 14 glasses of wine you're drinking a week are increasing your risk for breast cancer. So you're telling me actually by your actions, you're okay with breast cancer. And of course, many women don't even know that there's a connection. Belly fat is a big risk for breast cancer. And so in looking at these choices that we might have to reduce our risk for cancer, most women don't know that diabetes and belly fat and high blood pressure is a very significant risk factor for uterine cancer. So again, there's lots of things that we can look at and we can support you in reducing your risk for cancer. And at True, it's important that we support you as a whole woman, including the thought of the risk of or the treatment of cancer. So on that note, again, I want to remind you that we're very happy to take your questions on our Facebook. Please check out our website. I'm very proud of it. One thing I'd love you to do is go to the website and look at tools. On tools, I'm so proud. Missy and Joe at Leverage, who handle our communications in our website, have invented the symptom circle online. So I invented the symptom circle, which is a circle that has all the symptoms around the outside, and you spin it and you can tell what you can do to make the symptoms better or worse. Joe figured out how to get the symptom circle to spin on the website. So if you go to the website, go to tools, go to check your symptoms, the symptom circle will pop up and you can click on it and it spins. Of course, I had happy tears when I saw that. I thought it was so cool. But again, I want you to know you're not crazy. The symptoms are real and there are real solutions that we can help direct you toward. So again, please check out our website. We're happy to help any way that we can. And I wish you a good night and just let us know how we can help. Thank you.